Perfect. We're live on YouTube now. Hi everyone. Good evening and welcome to today's lecture. My name is Stephen and I'm the series coordinator and also a board member at UIMS. Today we're really excited to have Dr. Priyanka Iyer talk to us about the Obs and Gynae exam. This is an exam that she's very passionate about, and she's heavily involved in Obs and Gynae in her free time and also in her academic careers and academic foundation program doctor in the UK. So we're really glad that Dr. Iyer is here to talk to us and to teach us and to share all of her wisdom that she's picked up over her rotations. So Dr. Iyer, if you wouldn't mind just moving on to the next slide. So I think you can all see, and you probably all know by now that we do have a series giveaway. You've probably heard this a million times now. You've probably heard my voice talk to you about this, but please stay till the end because that is when we will release the feedback form. And as soon as you complete the feedback form, we will add you to our list of students who are entering this draw. As you can quite clearly see, the prizes on offer are amazing. So prize one, you can win a os implant skull, a QuesMed single best answers question bank access, a Oxford Handbook of Clinical Examination Practical Skills, and also prize two, which is equally as awesome, is a My Suture kit and also digital pod cases by Scrubbed In as well. So just to repeat myself, if you stay till the end, I'll release the feedback link, and the feedback QR code will also be visible on the screen as well. So please do stay towards the end in order to enter this draw, and you'll also get a fantastic and very neat certificate for your portfolios by Medall as well. So yeah, with that, thank you for listening. Thank you, Dr. Iyer, once again for being here, for teaching us this exam. And I'll leave the floor up to you now. So thank you.
Amazing. Hi, everyone. I'm Priyanka, and thank you so much for having me give this talk. I graduated from King's last year, and I'm working as a foundation year one doctor in Northeast London. So I'm quite passionate about obstetrics and gynecology. It's something that I really enjoyed. So I really enjoyed surgery actually in med school, and then I did obs and gynae, and I thought that it was a really nice mix of medicine and surgery. So I'm hoping to sort of apply to training next year. So this is just part of some like medical education stuff that I've been doing this year. Thank you so much to everyone that's attending. And just very quickly, before we begin, with any questions that you guys have, I'm more than happy to take any questions. So what we're going to do is we're going to split this into two. So we're going to do the gynae exam first, and then I'll take any questions that you have about the gynae exam straight after that. And then we'll do the obstetrics part, and then we'll take any questions after that. And then I'm happy to take any general obs and gynae questions, and I'll try to answer as best as I can. So I did an obs and gynae rotation at the beginning of F1, which was amazing. So hopefully I can sort of try and give some like clinical bits as well as and when I can. And if I think my internet connection might be a bit unstable. So if you aren't able to like hear what I'm saying, or if it's cutting in and out, just let me know and I'll just stop my video. I think that helps sometimes. Okay, so let's get started. This should hopefully be maybe an hour and a half, maybe less than that. So we'll see how. So let's start off with the pelvic exam. So here's your first case. So we've got Ellen, who's a 27-year-old who presents to ED with bilateral lower abdominal pain for the last 5 days. So just to sort of try and get some interaction going. So what sort of questions would you guys want to ask Ellen? Let's say you're the senior house officer in the emergency department. You're a junior doctor there and you need to clerk Ellen. So what sort of questions do you want to ask her? What's going through your head?
I think if everyone could just use the chat box to share your thoughts. Everyone's muted, unfortunately.
Oh, yeah, sorry. That's what I meant. I meant if you can type in the chat box. Infection, yeah. So yeah, that's correct. Infection is one of the things, and that is sort of like the top differential here actually, because you're thinking bilateral lower abdominal pain in someone who's quite young. So that could be one of the differentials. So some of the questions that you want to ask with anyone that comes in with pain is, so we think Socrates. So, the site of the pain. So where exactly is the pain? So it's bilateral lower abdominal pain. How would she describe the pain? So she describes it as quite sharp in nature. She doesn't say it radiates anywhere. She feels quite nauseous with the pain as well. And she says it's sort of an 8 out of 10 in severity. So she also, some other sort of like, when you ask her about sort of like her sexual history a bit more, she says she's also noticed some slight vaginal bleeding and brown discharge. She's also noticed some pain during intercourse as well. And if you sort of ask her a few more questions, she says she's had a new sexual partner last month and she rarely uses condoms. She's had previous STIs. She's been treated for chlamydia and gonorrhea. And she has no other significant past medical history, no drug history or allergies. So what would you like to do next? So essentially you've done your history. The next thing you want to do is sort of the other thing that you can do by the patient's bedside, which is your examination. So I've split the pelvic exam into 3 parts. So you've got before the exam, then you've got during the examination, and what you do after the exam. So before the exam, we're going to go through a useful mnemonic, which is WIPE, which sort of just, reminds you of all the things you need to do before you start any examination. It works for all the exams that you'll have to do during med school and beyond. And the next one is explaining the procedure, which is actually even more important with obs and gynae exams. It can be really awkward for the person doing the exam, but believe me, it's probably just as awkward for the patient as well. So it's really important to just make the other person feel comfortable, to use words that are quite informal, but also stay professional at the same time. So explaining the procedure is really important. And patient positioning as well, because often with speculum exams and stuff, patient positioning is so important to actually whether the person's going to tolerate the speculum or not. And then just some questions to ask as well before you actually do the exam itself. And then during the examination, you can sort of split the pelvic exam or the gynecology exam into 3 parts. You've got your external exam, you've got your speculum exam and the swabs, and then you've got your internal examination. Some people also call it the bimanual or the vaginal examination. And then after the examination, I mean, this is just the usual stuff that you would do. So thanking the patient, asking them if they have any questions. And then if you are in sort of like a practical exam or like an OSCE situation, you'd summarize your findings to the examiner. And often that's like the most stressful part because you have to sort of like bring everything together. So before the examination, so just remember Clinell wipe. You're probably going to think that this person's just gone absolutely crazy, but just remember it because it's quite useful. So you've got wipe. So the W is wash your hands. I, introduce yourself to the patient, then check the patient details. And then E is explain the examination. Why is it necessary? And then the C for Clinell. So just remember these, and this is really important, especially for any intimate exams, is consent and chaperone. And when you're documenting, you need to always remember to document sort of like who chaperoned you for the examination as well. So that's all the things to remember before an examination. And that's like your, that's your standard protocol before any clinical exam. And then when it comes to explaining the procedure, so you need to tell them that this is an internal examination, that it involves placing 2 fingers into the vagina and inserting a small plastic tube to have a look at the cervix. And some people might not know what the cervix is. And you can just say that the cervix is basically sort of like a donut-shaped structure, and it's sort of the entrance to the womb or the uterus. And then you just have to say, like you would with any examination, it shouldn't be painful, but do let me know if you're uncomfortable or you want me to stop. It's sort of your catchphrase, even when it comes to like urinary catheters, PR exams. It's just the thing that you just say. And then there will be a chaperone present as well. So that's another thing that you should say. So, you don't have to say this word for word. It's just try and practice it so it comes out natural. And it's sort of, so because if you are comfortable saying it, you're going to make the patient feel comfortable as well. And then positioning the patient. And this is, again, really important, especially for speculum exams as well. And your sort of like a bimanual or your vaginal examination. So the patient lies on her back. You need to ask them to undress from their waist down. I need to ask them to put their heels together and bring them as close to their bottom as possible. And then ask them to flop their knees outwards. And that's sort of like the positioning that you want them to be in. And I just put this in because, it can be really awkward, but you just have to try and make it as comfortable as you can. And that's important, not just for you, but also for the patient as well. Just because, a person is not going to tolerate a speculum exam if they're really nervous, if they're really anxious. It's just going to make it really, really difficult for them. And then you're not going to be able to visualize the cervix and you're going to have to try and go again. So it's just about trying to sort of like before the examination is just so crucial to actually trying to successfully complete the exam. So just some questions to ask before you begin. So in any sort of like obs and gynae sort of history, I just try and ask these 4 things. So you want to ask about sexual history and cervical smears. You want to ask about contraception. You want to ask about urine and bowel symptoms. And then you want to ask about their menstrual history as well. And then in addition to that, you want to ask about bleeding when there shouldn't be bleeding. So bleeding between periods, bleeding after sex, and then bleeding after the menopause. So those are the 3 ones that you also need to ask about as well. And really important for any woman. So any woman that comes in with abdominal pain, with vomiting, you have to do a pregnancy test. So yeah, just always ask any chance that you could be pregnant. And even if they say no, you would still do a urinary pregnancy test and just let them know that this is a standard protocol for anyone of childbearing age. Okay, so that's sort of like everything sort of before the exam. Now the examination itself. So when it comes to the external examination, you want to do a basic lower abdominal examination. So again, so with that, you'd think inspection, then you want to palpate, you want to percuss, and you want to auscultate. So what are you looking for? You're looking for any abdominal distension. Are there any scars from any previous surgeries? You might see a phalangeal, which is basically like the cesarean section scar. You might see some like small scars from like previous laparoscopic surgeries. It might be quite distended. On palpation, you might be able to feel masses. You might, they might be particularly tender. You might feel peritonism as well. So you might feel things like rebound tenderness. You might feel guarding, which are both signs of peritonism. And percussion. So if someone comes in with ascites, for example, then you might check for shifting dullness. You can check for organomegaly. And on auscultation, you want to check for bowel sounds. So that's sort of like your basic lower abdominal examination, which you would do anyway. But always remember that that's also part of the gynae exam. So you need to do that as well as part of your external examination. And the next bit is sort of like inspecting the vulva. So you put gloves on, you part the labia with your non-dominant hand. So the things that you're looking for is any kind of masses, any infection, any ulceration, cysts. So you can get Bartholin cysts. You're looking for like erythema as well. And you want to ask the patient to cough to check for uterovaginal prolapse. So that's all of your inspection, and that's your external examination. The next bit, the speculum exam. I think there are loads of really great videos for this. And the best way to just get really comfortable with speculums is just to try and take every opportunity to do them. So, when you're in placement, just make sure that you take the opportunity, just get the consent from patients. A lot of patients, if you ask them really nicely, they're more than happy for you to do the procedure, as long as you're being supervised by someone else. And trainees are really happy to supervise you. So I think that with this procedure, the times that I did it during obs and gynae, there were many times where I wasn't able to find the cervix, and it's fine. It's just some people's cervix is just much easier to find than others. And it's just, it's just trying to improve your technique as much as you can. And the more you do it, the more comfortable you're going to be. So just some top tips with speculum exams. So find the light source, which is actually the most difficult part. I've seen a number of times we've just been running around DD trying to find a light for like a speculum exam. And they're actually really difficult to come by. And obviously you can't use your phone light. People use it, but it's just not good practice, really. You don't want to be doing that. So yeah, you want to find a light source, which is often the hardest part. And then you want to find everything for the speculum examination as well. So you want your speculum, you need your KY jelly or lubricant jelly. So it's to actually just, get all of your kit together. And then you want to lubricate the sides of the speculum really well, because that's what's going to make it much more comfortable for the woman. And then warn the patient before you insert the speculum. That's a given. That's obviously something that you would do. And the other thing, so you need to insert it with the screw sideways. And then as you go in, you sort of rotate the speculum as you advance it. And you can do it 2 ways. I've sort of put it with it facing upwards, but some people put it downwards as well, like it is in this photo. I think it's just personal preference. So essentially you put it in sideways and then you rotate it. And then you tighten the screw when you feel resistance, essentially. And that sort of like keeps it open. And then inspection of the cervix. It's similar to like when you inspect anything, really. You're looking for bleeding, you're looking for signs of infection. You might look for an ectropion. as well. So that's sort of where the columnar cells on the inside of the cervix are found on the outside. And you can get that with pregnancy, you can get that with the oral contraceptive pill. And that's a common cause of postcoital bleeding as well. But the thing to remember is if anyone comes in with postcoital bleeding, you want to rule out a cervical cancer. But this could be one of the differentials. You might also see a polyp as well, which could be another cause of postcoital bleeding. Fine. So you've put the speculum in, then you have a look at the cervix. And you're looking for all of these different things. And if you cannot find the cervix, a really handy tip that my obs and gynae registrars told me was you basically ask the patient to make a fist and ask them to place this under their lower back. And that it sort of just helps position it a bit better. So it might just makes it easier for you to actually visualize the cervix. And it works really well actually for a lot of women. Fine. So when it comes to taking swabs, there are often 3 different swabs that you have to take. And we'll go through each of them. And there's a particular order that you have to take them in. You the charcoal swabs first. There's 2 charcoal swabs, and then there's one just like a normal swab. So the charcoal swab, so first you start off with the high vaginal swab and basically just do a circle around the high vaginal wall. You just do 1 circle, and that swab basically goes for BV. It goes for Trichomonas vaginalis. It goes for Candida and Group B strep. Then you've got your 2 endocervical swabs, one for gonorrhea and then one for chlamydia. And this just tells you exactly how you would do that procedure. And that's basically what a charcoal swab looks like. You'll be able to see the charcoal in the swab. And then this is what the endocervical swab looks like. It's just sort of like a yellow top. But I guess the colors just are different depending on what hospital or what trust you're at. Fine. So we've done the external examination. Then we've done the speculum exam and how to do a swab. And then the last bit's the internal exam. So this is just a really useful picture just for you to sort of visualize exactly what it looks like and what, because the thing that I found really challenging with the internal exam is that like you're often just, you're going in completely blind. So it's really useful to sort of know exactly what you're feeling and what you expect to feel when you're doing an internal exam. So just like quickly looking at the anatomy. So the 2 bits that are really important, your posterior fornix, so that's the bit right behind the uterus. And then you've got the lateral fornix as well. So that's on either side. Fine. So again, you'd put gloves on, you'd lubricate your fingers, you'd part the labia with the non-dominant hand, and you want to insert your middle and index finger, sort of like entering sideways. And then you rotate your hand as you enter so that your palm is then facing upwards. And you want to enter the posterior fornix, which is where that diagram is really handy. And that's where you check for cervical excitation. So why is this important? You would see cervical excitation. You don't always see it. So it's not the most sort of like sensitive thing. But if you do see it, then it makes it more likely that it's going to be something like PID or maybe an ectopic pregnancy. And you can also check if the uterus is anti or retroverted. I mean, most cases it's going to be antiverted. And I think it's very, very tricky. You probably have to have done a lot of internal examinations to be able to really pick that up. That's something that you can check for in an internal exam. The next thing you check for is the size of the uterus. So some of the times when the uterus would be enlarged could be, for example, if the woman's pregnant or if she's got fibroids. Those could be 2 of the situations where it might be enlarged. You want to check for mobility, you want to check for tenderness, you want to check for shape as well. So if the uterus is enlarged and it's quite tender, it could be something like adenomyosis, for example. If the uterus is very fixed, then you're thinking, could this be endometriosis? Could this be PID? Which is sort of where you get this frozen pelvis, where everything is just so stuck down that you're not able to really, the uterus is sort of just like stuck. So that's where you sort of like check for mobility, and that's where it's handy. So then you place your fingers in each of the lateral fornix to check for adnexal tenderness. And why is this important? Because that would be a positive sign in things like salpingitis, which is inflammation of the fallopian tubes, ovarian torsion, or an ectopic pregnancy again. So with all of these examinations, don't just remember it as sort of like a list of steps that you have to do. Try and remember it as why is this important clinically? And I think that's what helped me to like remember all the different steps. So be like, okay, I'm checking for adnexal tenderness, but when would I see this? Because often when you sort of do your clinical examinations, you're going to have a case, right? You're going to have a vignette, and you're going to have like a patient history, then you're going to have an examination after that. So it's really important to sort of tailor that exam to that patient that's in front of you. And then you want to remove your fingers and inspect for any blood or discharge. So that's your internal examination. And that's like the during examination part. of your gynae exam. And then after the examination, you want to thank the patient, you want to ask them if they have any questions, and then summarize back to the examiner if this is an OSCE. And document. In real life, you just have to document, say that you've done this examination, who you used as a chaperone, and what you found. So let's go back to Ellen, who was the lady with the bilateral lower abdominal pain. So you do a set of observations on her. She's tachycardic, she's pyrexic, her blood pressure is stable, respirate's fine as well. But just always remember that with young women, you can't rely purely on their blood pressure. It's often their heart rate that goes quite high. They can actually maintain their blood pressure for a really long time. So if a young woman is coming in with systolic of 90, you need to be scared. You need to be worried because she's been compensating for so long that she's finally sort of like dropped. So because I remember sort of like looking at a bunch of observations and I would sort of like go straight for the blood pressure. And actually that's sort of like one of the last things to drop. So I think the things they need to think about is like respirate. I think respirate is also a really sensitive sign of how unwell someone is, and heart rate as well, because that can quite mark it. That could be often like one of the first things that maybe go up in someone that is quite unwell. And then you do an abdo exam. Like I said, that's a really important part of the gynae exam, which shows you signs of lower abdominal peritonism. And then you do a bimanual examination as well, and you see bilateral adnexal tenderness and cervical excitation. So you've done a history and an examination. What would we like to do next? So you guys can put some answers down in the chat box. Okay, so I'm guessing that you mean an ultrasound? Is that what a USG is? Sorry, I think it's just different thing, different sort of abbreviations in different countries, I guess. Order investigations, yes. CBC, I'm guessing that's the same as sort of like a full blood count. Okay. Amazing. Yes. So you sort of you do all of your stuff by the bedside, then you do your bloods, and then you do sort of like any imaging or anything that you want to do. Perfect. So the next thing you want to do. So I put this picture down because this is something that like one of my seniors taught me in med school, and it's sort of like the end of bed test. And so let's go back to Ellen. Do you think that she's well, or do you think that she's sick? So let's try and do like an end of bed exam. Think about like the observations that you have, the abdo exam, the bimanual examination. What do we think about this patient? What do we think from like the end of bed test? So I would say the fact that she's tachycardic, she's pyrexic, I wouldn't say that this is sort of like a mild infection. I would say that it is sort of like a moderate or a severe infection. Good. Yeah, exactly. So her fever and abdominal tenderness may point to an infection. So like you guys said, we've done investigations. The first investigation you definitely want to do in her is a pregnancy test. Then you want to send off endocervical swabs for chlamydia, gonorrhea, blood culture. So she's septic. So you want to do the sepsis 6. So you want to do blood cultures. You want to do a full set of routine blood tests. You probably give her some fluids, do a venous blood gas to check the lactate. I wouldn't really catheterize her to check urine output, but just make sure that she is passing a good amount of urine. You don't need to catheterize everyone, but if she becomes markedly more unwell, then you might consider catheterizing her. But yeah, blood cultures before you give any antibiotics. And then pelvic ultrasound, exactly like you said. So it's really useful because it can help exclude things like an abscess, an ovarian cyst, an ectopic pregnancy. In ED, I don't know if you guys might have seen this as well. They're really good. They get very excited about like bedside ultrasound scans where they look for free fluid. So if you've got a ruptured ectopic, for example, you might look in the pouch of Douglas. You might look in I can't remember what this pouch is called. And so there's like I think it's Morrison's pouch. Yeah. So you check Morrison's pouch as well for free fluid. So they really like doing their sort of like bedside ultrasound scans to check for ruptured ectopic. Yeah, so you want to do an ultrasound scan as well. So someone said infection earlier, actually, because they said the peritonism, the fever. So what are some of your differentials in this case? What are people thinking is going on? PID. Yeah, exactly. Anything else that thinking outside the box that this could be? Yeah, could be. Retained tampon. Anything else? If you think outside of your gynae realm, because I know this is an obs and gynae sort of talk, but thinking outside of obs and gynae. Because, yeah. What else could it be? Appendicitis, yeah, that's what sort of I was getting at. I know it's bilateral abdominal pain. UTI as well, really good. Always sort of think gynae, but it could also be gen surge or like your gastro stuff, or it could also be urinary as well. So perfect. I'm really glad that you guys said that as well. But yeah, appendicitis as well, which is sort of a very, so right-sided lower sort of abdominal pain is a very contested area. And there's like gynae will be fighting for its surgeons. I mean, they're both fighting to not take the patient, but it's sort of like a very contested area. Everyone's like, is this appendicitis? Is it PID? Is it ovarian torsion? Left-sided is a bit more straightforward. It's very unlikely to be appendicitis. So yeah, so gynecological things, it could be an ectopic pregnancy, it could be an ovarian cyst rupture, general surgery could be appendicitis as well. So management, so things that you want to give. So this is PID. So the things you'd give for PID are painkillers. You want to give antibiotics. So it's actually 14 days of antibiotics that you give. And you don't need to remember these specific antibiotics. I suspect it's probably going to be different depending on which hospital you end up working in. But you just have to check whichever hospital what their guidelines are. But basically for mild pelvic inflammatory disease, you can just give oral antibiotics and you can just send them home. If it's severe, so she would classify as severe because she's got pelvic peritonitis. She's pyrexic. They might have clinical signs of tubo-ovarian abscess. So with an abscess, you might get like a swinging pyrexia. So the fever sort of like goes up and down. You might see that on an ultrasound scan as well. And in that case, you'd give them IV Kef and then give them Doxy and Metro as well. And then if there's no significant improvement after 24 hours of antibiotics, you might consider laparoscopy because it might be that they have an abscess, which means that they haven't, which need to go in with a laparoscopy and drain that abscess. Yeah, and then you basically do lap or ultrasound guided drainage. Usually they just do lap. And then you might have to offer treatment for the sexual partner as well. So quickly going through PID. So it's basically an ascending infection from the cervix. It's often due to STIs, but it doesn't have to only happen in people who are sexually active. So it can happen in someone who's never been sexually active before. And essentially it's ascending infection, and this can then give you infection and inflammation of the female pelvic organs. And risk factors are prior STI, recent new sexual partner, having multiple partners, if you've got a history of PID, unprotected intercourse. And as you can see from the history, Ellen had a lot of these risk factors for PID, which put it quite high up in our differentials. The most common organisms are chlamydia and gonorrhea. And essentially the pathophysiology is you have this ascending infection, which gives you inflammation. And this then over a period of time, it can give you scarring, adhesions, and it can give you partial or total obstruction of the fallopian tubes. And this is sort of like a pictorial representation of what you might see. This is sort of like your frozen pelvis, like I said before, what you might see if you do a lap and then you sort of see everything stuck down together. So you see these adhesions, you see a swollen blocked fallopian tube, and you might see adhesions between the fallopian tube and the bowel as well. Some of the complications of PID. So does anyone know what those adhesions are in the figure in the bottom right? Fitzhugh-Curtis, yes, exactly. And what does that ultrasound scan show on the top? I don't expect you guys to be experts in reading ultrasound scans. I definitely am not, but just if anyone knows what that is in the top.
Is that a fistula?
So it's actually an abscess. It's a tubo-ovarian abscess. Yeah, so that's one of the complications that you can get in PID. So there's a useful mnemonic. I really like my mnemonics. It just like helps me remember things. So useful mnemonic is I face PID. So you can get things like infertility. We mentioned the Fitzhugh-Curtis syndrome, which is between the liver and the abdominal wall. And that can give you sort of like right upper quadrant pain as well. And we can get an abscess, like we said, you can get chronic pelvic pain, which unfortunately we're not very good at, treating. Ectopic pregnancy, you can get peritonitis, intestinal obstruction as well from all of those adhesions that you can get, and disseminated infections, which are really unlikely these days, especially because we've got really good antibiotics to treat it, and people don't really present, really, really late. So you can get disseminated infections, so things like endocarditis, meningitis. So just some differentials for acute pelvic pain. So you've got your gynae, you've got your gen surgeon, you've got your urological differentials. So gynae ones are ectopic pregnancy, could be a miscarriage, ovarian accidents, so things like rupture, torsion, hemorrhage, pelvic inflammatory disease, like we said, and Mittelschmerz as well. So non-gynae things can be things like appendicitis. We mentioned UTI, could be stones as well. So yeah, those are the main things when it comes to acute pelvic pain. Just think, what kind of gynae stuff could it be, and what about the non-gynae stuff? Have we considered this in the differentials? And then finally, just summarizing your exam. So this is a really accurate description of what I probably look like when I'm sort of, presenting to my senior, or just like referring a patient to like the med reg, like the surgical reg. So it is really stressful to like, because, you've spent a while with this patient, you've like asked them so many questions, and you just have to like very succinctly wrap everything up in a few sentences. So just a few tips. So just remember, it's all about presenting them with a story. You want to give them the key positive, but also the key negative findings as well. So use SBAR, which is a really good tool for when it comes to like handing over, when it comes to presenting a patient. So what is the situation? What do you have? I've got a 27-year-old who's come in with this. What's her background? She's had multiple sexual partners. She doesn't use condoms. She's had previous STIs. That's all of the background. Then you talk about the assessment. What did you find in your history, in your examination? I mean, it's really important in this case. You'd be like, she's tachycardic, she's pyrexic. And then recommendations. So what have you done for this patient? And then say what you're concerned about at the start. So I've got a 37-year-old who I think is coming with PID. So that's sort of like your starting statement. And then you sort of take it from there. So yeah, that's just very quickly summarizing your examination, whether it's sort of like for an OSCE or like a practical exam, or if you're a junior doctor and you have to sort of summarize it to a senior. It is really stressful. And I think the more you do it, the more you sort of pick up the nuances of like the kind of things to say and the kind of things not to say. Just the more you do, the more you sort of get a bit more comfortable with it. So very quickly, we'll summarize the pelvic exam. So before the examination, remember, wipe. So wash your hands, introduce yourself, check the patient's details, and explain the procedure. And then C is your consent and your chaperone. Then you remember explaining the procedure, positioning the patient, and some questions to ask as well. So during the examination, you've got your external exam, both the abdominal and the inspection of the vulva as well, and then checking for prolapse. You've got your speculum exam and your swabs, and then you've got your internal exam. And then after the examination, thank the patient, ask them if there are any questions, and then summarizing to the examiner or your senior. So yeah, so I think that's the gynecology exam. I'm happy to take any questions if anyone has any questions now.
Thank you. There's one question. So the question was, when choosing the type of antibiotic, obviously it depends on the hospital you're working at, but do we also not have to depend on culture results?
That's a good point, but the problem is, realistically, culture results take a few days to come back. And so if you send off a blood culture, for example, so if you're treating someone for, let's say, I'm trying to remember. Okay, let's say you're treating someone for UTI. So you'd give them, so you sort of treat them. I think why hospital guidelines are sort of like important is it sort of tells you, the patients that are coming into your hospital, what sort of, antibiotics they're resistant to or sensitive to and stuff. I think it just tells you like your blanket antibiotics to give. I think usually it doesn't differ too much between hospitals, but I think it's just always useful to see what's being used in your hospital. So it's sort of we have like a microguide app which tells us what sort of what antibiotics to prescribe in NEUM, for example. So you do prescribe sort of like your empirical treatment, which covers most of the different bugs that could be causing a PID, for example. And then you get the culture and sensitivity results. And it might tell you, oh, it's actually resistant to this. And then you sort of like put them on another antibiotic. So yeah, so the reason why we don't just depend on CS results is if we can't just not treat them and wait for this culture and sensitivity results to come. So in real life, what they do is they give them quite a broad spectrum or what we call empirical treatment. And then depending on the culture sensitivity, we might decide what we can, because you always usually start off with IV if the patient's really sick. And then the sensitivity results are back. And then you can see what sort of like oral alternative you can switch them to. So I hope that sort of answered the question. Are there any other questions?
I think that's it.
Okay. So we'll move on to, let me see how we're doing for time. Okay, not too bad actually. So we'll move on to the obstetrics exam, which is a bit more different to the other exams that you're used to, I guess. I think the gynae exam is quite similar especially because it's got the abdo exam, which you're already sort of like a bit more comfortable with. So again, I've divided up into before, during, and after. So before the exam, exactly the same. So wipe, so wash, introduce yourself, patient details, and explaining the examination. And then patient positioning again, and then just ask them a few questions. So with obstetrics, what kind of questions do you want to ask them about? So you're seeing a pregnant woman. What questions would you ask them? So yeah, what sort of things? How many weeks? Exactly. That's a very good place to start. What else would we want to ask them? LMP, good. Any problems so far? What do you mean by any problems so far? What kind of problems are we going to ask them about? Headaches, bleeding, good. Vomiting, yeah. Any other symptoms that you might get in pregnancy? Previous pregnancies, amazing. That's really good. And what do you want to ask about previous pregnancies? It's everyone's favorite, gravity and gravidity and parity. Yeah, exactly. Anything else? Any other symptoms that you want to ask them about? So we've got some already. Headaches, vomiting, bleeding, leg pain. Yeah, that's a good one. Anything else? I'm thinking about like obstetric cholestasis. What kind of symptoms would we get in that? I know OC is not very, very common, but what kind of things would you get with that? Shortness of breath is a really good one, actually. Yes. Anything else? Right upper quadrant pain. Yeah. What else would someone with obstetric cholestasis present with? Jaundice. Yes. Very good. Anything else? Constipation. Yeah. Constipation is quite a common symptom, actually, that people get in pregnancy. Anything else? So the other thing that you can get in obstetric cholestasis, because you've got sort of increased amounts of bile acids, you can get like itching as well. So they can get a lot of itching in their like palms and the soles of their feet. Change in urine or color of the feces, good. So if you're getting like that's the cholestatic picture. That's really good. Yeah. Anything else? Any other symptoms that you might get just in pregnancy in general? I think you guys have pretty much covered most of it. And you sort of want to ask about their previous pregnancies, and you want to ask things like, how did they deliver? Did they have any complications in that pregnancy? And I always ask specifically about diabetes, and I ask about preeclampsia. Those are like my go-to conditions that I ask for, but you want to ask them about anything else as well. And then during the examination, again, so you've got your inspection, you've got your palpation, and you've got your auscultation. And after the exam, again, these are the exact same as we had in the gynecology exam. So when it comes to inspection, so you've got your general inspection, like I said, the end of the bed test. Is this a sick patient or is this like quite a well patient? And you don't have to, you can sort of like take your own time with it. Do they look breathless from the end of the bed? Like I said, do they have jaundice stare? Do they have conjunctival pallor? Could they be so anemic that that's explaining why they're so breathless or why they've had a syncopal episode, for example? Legs and feet. So you would expect a certain amount of like peripheral edema, which is why it's very tricky, because peripheral edema, yes, it can be a sign of preeclampsia, but it's common to be sort of like quite swollen, have quite swollen ankles, quite swollen legs in pregnancy. But I think the key part is how quickly the edema came on. So in preeclampsia, classically, the edema comes on quite quickly, just like it develops very quickly over like a period of days or like a week or so. And then you want to look at the abdomen. So you want to check for abdominal distension. You might see fetal movements if it's much later on in pregnancy. Check for any scars, any skin changes, and just palpate all 4 quadrants. Because you might get things like epigastric pain and preeclampsia, for example. And ask them to cough for any hernias, which hernias are quite common because you've got this increase in intra-abdominal pressure. So it is common to have things like an umbilical hernia, for example, in pregnancy. So just some pictures. I'm going to ask you guys what these show. So what does this picture show you? What sort of sign? Linea nigra, exactly. Good. What is that? She's sort of like just itching her palm. It's got like excoriation marks all over her body. Pruritus, yes. And what does it make you worried about? Like, what is the thing that you like? Because it could just be that she's liver, HELLP syndrome. Yep. Anything else I can give you? Itching? because it could just be like a dermatological condition, for example, but you want to think about like the worst case scenario and you want to do those investigations to rule them out. So the other thing that I would think about is obstetric cholestasis. So in someone that comes in with pruritus, check for jaundice, and I would probably send off like liver function tests. I would check their bile acids as well, because their bile acids will be high in obstetric cholestasis. And the reason why it's really important to identify obstetric cholestasis is because it increases the chance of you having a stillbirth. So often if these women are picked up earlier, you can induce them earlier, so then they don't end up having a stillbirth later on. And what is this? What's the fancy term for this? Abdominal striae. Yeah, so it's actually striae gravidarum. There you go. That's the fancy word for that. So yeah, those are just some of the things that you might see in a pregnant abdomen exam, and you can like really impress your examiners by throwing things like linea nigra or striae gravidarum. So the next thing you want to, so you've done your inspection, you've done the general end of bed inspection, you've done your abdominal inspection as well. The next thing you want to do is palpating the fundal height. So you want to start off, so you use the ulnar edge of your hand until you find the first bit of resistance, which is going to be the fundus of the uterus. And then you go all the way down to the pubic symphysis. And often when I was doing this examination, I would get too awkward to ask the woman to sort of like pull her trousers down. And actually it's really important to do that, because you're going to massively underestimate the symphysiofundal height. So it's really important to ask her to really lower her trousers so you can reach all the way down to the pubic symphysis. So that's just a place where I used to always sort of like trip up. And then tape, it's just to eliminate any bias. You want the tape sort of like facing down, and then you go all the way, and then you sort of like turn it over to check it. And just some like important key things with fundal height. So at 12 weeks, the fundus should be, you should be able to palpate it. At 20 weeks, it should be near the umbilicus. And at 36 weeks, it should be near the xiphisternum. And essentially until 36 weeks of gestation, the rule of thumb is, for example, if a woman is 23 weeks pregnant, so the symphysiofundal height, so it's symphysio is the pubic symphysis, fundal is the fundus of the uterus. So the symphysio-fundal height should be, for example, if it's 24 weeks, should be 24 plus or minus 2, anywhere up to 26. And so it's anywhere between 22 to 26. And I mean, it's not the most sensitive test. It's useful, but like it's not super sensitive. What's probably much better is actually just doing growth scans and ultrasound scans. But it's a good sort of like measuring tool. So when you do the symphysio-fundal height, it can either be too big or it can be too small. So if it's too big, it's either, the baby is too big or there's too much fluid around the baby. So macrosomia, the baby is too big. It could be polyhydramnios. So there's too much amniotic fluid in there, which is why the symphysio-fundal height is way bigger than what you'd expect. Or there could be a multiple pregnancy. Or the woman could have fibroids, which is why it just looks a lot bigger. Or it could be too small. So it could be IUGR, which is intrauterine growth restriction. You can find that in preeclampsia. It could be oligohydramnios, which is where there's too little fluid around the baby, or it could just be a small baby. So in palpation, you've done the fundal height. The next thing you want to do is check the lie. And essentially, when you check the lie, you basically just have to like face the woman. So you sort of stand on one side and you face the woman's face, essentially. So you turn towards her face. And there's 3 different things that it could be. It could be longitudinal, which is where you could either have the head, which is the cephalic, that's the presenting part. Or you could have a breech presentation as well, which is what the second photo shows. Or you can have an oblique lie, which is sort of like more of like a diagonal lie, or you can have a transverse lie. And as you can see, 99% of babies would be either cephalic or breech presentation, and cephalic is the most common. The thing so when it comes to like checking the lie, it's very tricky, and I think it's really difficult in some women, and it's fine to not get it right. You just have to sort of like commit to one thing. And essentially the way you do it is when you can feel like a continuous hard part, that's more likely to be the baby's back. And then you can feel lots of sort of like little lumpy parts. That could just be like the baby's hands or the baby's like feet. So that's how you know. So the thing that you want to look for is once you get the baby's back, you sort of know if it's longitudinal, if it's oblique, or if it's transverse. And if you sort of like push with one, push on one side and then palpate with the other. It just makes it easier, because otherwise it's a bit too fluctuant for you to be able to feel anything. So so you just push on one side and then you try and palpate with the other, and do the same thing. So you push with the left and then just try to palpate on the right. And that's just an easy way. It's really difficult to sort of like explain, but I think if you try and like see if you can feel the baby's back, that's the easiest way to sort of guess the lie of the baby, to guess the fetal lie. And the next thing, so you do the fundal height, you do the lie. So you want to know if it's longitudinal, oblique, or transverse. And then you do the presentation. So the presentation is a lot more important, sort of like over 37 weeks. And it's essentially which part of the baby. Is it the bum or is it sort of like the head? So you want to know if it's cephalic or if it's sort of like a breech presentation. And the way you check for presentation is you sort of go around and you so you place your hands on each ACES whilst facing the woman's feet. So you sort of like turn around to check the presentation. And yeah, the things that you want to know is it cephalic or is it breech? And engagement is basically how much of the head you can palpate in the abdomen. And it's measured in 1/5. Essentially, the less you can palpate, the more engaged the baby's head is in the pelvis. And you wouldn't be expected to get any of this sort of like with, like, it isn't an exact science. And I think you sort of like get a feel for it the more examinations you do. And I think as a medical student, even as a junior doctor, when we aren't expected to get this, we just have to know what you would do in a pregnant examination. So what the different steps are and how you would demonstrate it. They aren't too fussed about whether you've got the answer right or not, because they know that it's sort of like quite a crude way of checking live presentation. Actually, the best way of doing it is just doing an ultrasound scan, but it's just good to know what the steps are and what you're looking for. Fine, and the very last bit is auscultation of the fetal heart. So you want to basically find the back of the fetus. So that's what I said was the continuous sort of like hard bit. And you place the sonic aid, which sort of looks like this. You place it sort of right behind the anterior shoulder. So it would be halfway between the umbilicus and the ACES on the side of the back. So if the back is here, then you basically would just check over there. So it's just behind the anterior shoulder. And if you are unsure, just try on both sides and just see where you could pick up the baby's heart. And it's really important to feel for the mother's pulse at the same time to make sure you're not just picking up the mom's pulse. And the baby's pulse should be anywhere between 110 to 160. And it's heard when the baby is over 24 weeks gestation. And you want to ideally measure it for 1 minute. But yeah, that's a device that you use. It's sort of like, yeah, it's got a little scanner thing. You just put the jelly on there and then you listen. Fine. So just to summarize the obstetric exam. So before the examination, it's all the same as you would for any exam. During the examination, you've got the inspection, you've got the palpation. You palpate for 3 things: fundal height, the lie, and the presentation. And then you want to auscultate the fetal heart as well. And then after the examination is the exact same as you would before. So here's your second case. So you've got a 25-year-old woman. She's 25 weeks gestation. This is a very sort of like classic vignette. She presents with constant lower abdominal pain, small amount of vaginal bleeding. On examination, her blood pressure is 90/60. So what are some of the things that we think this could be? So you've got bleeding in someone who's over 24 weeks pregnant. What are some of your differentials for bleeding in this part of pregnancy? Placenta previa, yeah. Anything else that we would be thinking? Rupture? Do you mean abruption? Miscarriage as well. So I think with miscarriage, it's tricky because the definition of miscarriage is sort of like a loss in pregnancy under 24 weeks. So if it's over 24 weeks, you would actually call it a stillbirth. So yeah, so it would be, we would say stillbirth actually, if you sort of like lose your pregnancy after 24 weeks. Abruption, yeah. So that's definitely, it's your second sort of like differential. What are some of the rarer causes of sort of like bleeding later on in pregnancy, so over 24 weeks? They're super rare. But the 2 main things that you are concerned about are placental rupture. Hematological conditions, possible, yes. Infection, yes, maybe. That could always give you bleeding in any part of pregnancy. That's true. Accreta, yes, possibly. What's that condition called where you've got the umbilical vessels that run just across? And then you might get sort of like torrential bleeding as soon as the water breaks. So it's called vasa previa. So it's sort of like where the umbilical cord vessels are the first things that present. So if someone sort of like they rupture their membranes, that sort of loss of pressure causes like a huge amount of bleeding, and you can get things like fetal bradycardia, so the low heart rate on like the fetal monitor as well. That's another thing that can give you bleeding. And the other super rare thing is sort of like a uterine rupture. And that's more common in someone, for example, who's had 3 or 4 previous cesarean sections, and they've got constant abdominal pain. They've got this bleeding, that it could be a sign of uterine rupture. So in this case, the fact that she's got constant lower abdominal pain and a small amount of vaginal bleeding, and she's hemodynamically unstable, the thing that's most likely, I mean, this is a very classical case, and sort of like a case, I guess, that you might get in your exams or your MCQ questions. In this case, it would be placental abruption would be the most likely thing. The reason why is because of placenta. So it's the reason why it's placental abruption over placenta previa is because the placenta previa, classically, you would get painless vaginal bleeding. The woman might not actually be that sick. And with placenta previa, you might get sort of like herald bleeds as well. So like you might get some small, sort of like painless bleeds early on in pregnancy. Whereas placental abruption is, it's quite abrupt. So you've got this constant lower abdominal pain, you get this hemodynamically unstable, you might get fetal distress as well. So what do you think you might find on an examination if this was placental abruption? What kind of things? Let's say you did an obstetric exam. What would be some of your positive findings? Tenderness on palpation, exactly. So you might find, I mean, the classic thing is you'd see sort of like, you'd feel a woody hard uterus. I don't know how sort of like accurate that is, but that's what they say in all the textbooks. What is CMT? Oh, cervical motion tenderness, possibly, yes. The thing, so there is one thing that they always told us was that you don't want to do an internal exam if someone comes in with vaginal bleeding in later pregnancy. And I'm trying to think of why. I think it's because you're at risk of precipitating further bleeding. So you have to do an ultrasound scan to make sure that there isn't any placenta previa before you actually do a pervaginal exam. And I think just check that, but I'm pretty sure for placenta previa, it's actually contraindicated to do a PV exam. But if you have ruled that out, so if you've done previous sort of scans and you know that the placenta sort of like is much higher up, then it's fine to do a PV exam. Just something to keep in mind. Contractions, yeah, you might feel contractions as well. And the other thing is if you have sort of like when the fetal auscultation bit, if someone's 25 weeks gestation, they're quite unwell. You probably put on a CTG, which is where they do the continuous fetal monitoring. And on that, you might see things like fetal bradycardia, which is sort of like a really bad sign. So it's just a sign of fetal distress. Good. So, I mean, that emoji is just to say that this patient is really sick and you have to do something about this as an emergency. So placental abruption. So what is it? It's basically where all or part of the placenta essentially separates before the delivery of the fetus. And risk factors are things like if you've got intrauterine growth restriction, preeclampsia, hypertension, maternal smoking, previous abruption. The sort of like the golden rule in pregnancy is anything that's happened before is going to happen again. So a risk factor for gestational diabetes is having gestational diabetes before. A risk factor for preeclampsia is having it before. So it just increases your chance if you've had it before. How does it present? So constant pain plus or minus bleeding. So you might not always have, so the pain is sort of like out of proportion with the bleeding. You might have like very severe pain, just like very little bleeding. So just keep that in mind. Maternal collapse, you might get fetal distress on a CTG, which is a fetal monitoring, a woody hard or a tender uterus. And complications are sadly things like fetal death. You might get renal failure, that sort of stuff. How do we manage this? You want to admit this lady. You want to resuscitate her if it's quite severe abruption. And in that case, you want to, and if there is any signs of fetal distress, you want to deliver ASAP. If there's no fetal distress, if it's a preterm pregnancy, if it's quite a minor abruption, then you might be able to just do conservative management, which is just where you sort of monitor things maybe for 24 to 48 hours. The symptoms settle and you can send the woman home and just give her more scans or more frequent follow-up. And this picture just shows that sometimes you can have a concealed abruption. And that explains why you might have very severe pain but not that much bleeding. Because if you can see, the blood doesn't have, it's not actually tracked all the way down. So you might not actually have that much bleeding, as opposed to like a revealed abruption, which is where you might have a bit more bleeding. Fine. So when we look at bleeding in pregnancy, you can sort of divide it up into less than 24 weeks and over 24 weeks. So what are some of the differentials of bleeding if someone is under 24 weeks? What sort of conditions would you be trying to rule out? I guess what's the most important condition actually that you want to rule out? More important than miscarriage, I would say, because women can die from this. Say you've got PV bleeding in someone who is 8 weeks pregnant. So quite early on in pregnancy, I'm saying. Any guesses to what we'd want to rule out? So the thing that trophoblastic disease, yes, it can present with bleeding in very early pregnancy, but it's sort of like one of the really rare things. I think the thing that you have to rule out is it's an ectopic pregnancy until proven otherwise. Any woman who comes in pregnant under 24 weeks with PV bleeding, just because that's the thing that you're worried about, right? Because if it's a ruptured ectopic, there are women who have missed ruptured ectopics and they've sadly died. And these are really young women who shouldn't be dying. So it's similar to like a PE, for example. You're not going to find it unless you suspect it. So it's really important to like suspect ectopic pregnancy in someone who's under 24 weeks coming in with bleeding in pregnancy. Bleeding, abdominal pain, that sort of stuff. Always just think, could this be an ectopic? Miscarriage, like you guys said, that's another really common one. Molar pregnancy. So yeah, that's another cause of bleeding in early pregnancy. It might also present with other things as well. So because of the very high beta HCG levels, it can give you, severe morning sickness. You can present with someone who's large for dates. So molar pregnancy is the same as gestational trophoblastic disease, just another term for that. And then other gynae causes. So it might not be related to the pregnancy. It might be related to something like PID, an infection, cervical polyp, or cervical ectropion. Those are some of the other causes of bleeding in early pregnancy. And I guess those things can leave you bleeding even over 24 weeks as well. So those are just things to consider. And over 24 weeks, you've gone through that already. The two main things are placenta previa or placental abruption, but less common things are things like vasa previa or uterine rupture. Okay, so I think that's sort of covered the gynae exam and then the obstetric exam. Happy to take any questions if you guys have about the obstetric exam or just obs and gynae in general.
We have no questions on YouTube as well.
Amazing, thank you.
Anchor.
Can we get the slides? Oh yes, of course. I was going to say at the start actually that you guys, I'm more than happy to give you guys the slides.
If I could just interrupt you. So yeah, everyone will get the slides. We will upload them onto Medal once you complete the feedback. So yeah, as soon as you complete the feedback, we will upload the slides as a PDF onto the Medal event, and you will be able to access them and this recording on YouTube and also on Medal as well.
That's sort of just very quickly going through the examination. I just thought I'd give you guys some useful resources that I used for clinical exams. So you guys have probably heard of Geeky Medics. They're amazing. They just have they have really good checklists that you can use to test yourself for OSCEs. They've got great videos. I mean, I still use the videos. If I haven't done a catheter in a while, then I'll just Google Geeky Medics and just look through that just to make sure I have all the equipment and I have all the procedure, I know all the steps in my head. So they're just really useful, not just in med school, but just beyond med school as well. Most of the content of this presentation was actually from the OSCE revision guide. There's a really good website called OSCE Stop. And most of the things in the revision guide are actually on the website, but there's some things. So in our OSCEs, there was a lot of emphasis on the communication stations. So for example, in an obs and gynae station, we had a woman who'd come in and she wanted to be counseled on what contraception she can, what contraceptive options she could use. So the OSCE Stop is really good for those communication stations. So things like someone's had a seizure and for example, if they're an Uber driver, are they allowed to drive? So things you would inform the DVLA in the UK, you'd inform the driving authority. So like those kind of like breaking bad news. So it was really good for like the communications stations, but it was also really good for like the examinations, the history taking. It's got really good like tables for differentials and stuff. So yeah, it's a really good resource that I used for OSCEs and stuff. And I use it for this presentation as well. Just some useful obs and gynae resources. So Teach Me OBGYN is like a new thing that's come out of, I think you guys might have heard of Teach Me Surgery and Teach Me Anatomy as well. Those were really good resources. I sort of like used them mainly for like when I was doing anatomy and stuff in preclinical years. So Teach Me OBGYN is really good. BUSOG is a committee that I'm a part of actually. It's a British Undergraduate Society of Obs and Gynae. And they just do really great like webinars. They do they used to do like an annual conference as well. So if you guys are interested, if there's anyone interested in obs and gynae, they're a really good organization to be a part of. They do regular events. Osmosis is amazing just for like pathophysiology of any kind of condition. It's really good. It's very concise videos explaining things. Like, I mean, things like preeclampsia. I think there's a really nice video explaining the pathophysiology of preeclampsia on osmosis. This was a textbook that I used for obs and gynae. I'm not sure which textbooks you guys use, but I thought this was just really good. It's got really nice diagrams, very nice like tables. As you guys probably realized from this presentation, I really like my tables. So yeah, they've got some really nice tables in the textbook, which is really useful for like revision and stuff. And then just a cheeky plug. So I did a series actually. I did a clinical crash course for the British Indian Medical Association. And I just did like a set of 4-hour-long talks on obs and gynae. It was really fun to actually put together. But yeah, if you guys have like your exams coming up, or if you just want like a refresher on obs and gynae, I hope I've done it justice. It's difficult to cover such a vast topic in 4 sessions, but I sort of like did it based on the kind of things that would come up in med school and as a junior doctor. So it's all very like MCQ based. And then like I present you guys with an MCQ and then I go through like the content. But yeah, if you guys are looking for any kind of like videos and stuff, there's loads of videos out there. But yeah, if you wanted like a crash course series, that's just one that I did earlier on this year. But yeah, I think that's everything. Thank you so much to everyone that sort of like participated and for your interaction. It just makes it a bit, it just makes it nice, just like have that kind of interaction during the presentation. But yeah, thank you so much for everyone that attended. I'll hand it back to Stephen.
Yeah, thank you very much, Dr. Iyer, for your talk. It was really enjoyable and incredibly useful. And I just realized how much I forgot personally, so I'm going to have to revisit these. But yeah, thank you to everyone as well for participating and for sitting through and listening and interacting with Dr. Iyer as well. Dr. Iyer, if you wouldn't mind just moving on to the next slide.
Oh yes, of course. Yeah.
But yeah, just to plug us, if I could, next Wednesday we have our second part of our musculoskeletal exam. So Dr. Bay, who was the doctor talking about the MSK exam last night, will be talking to us again on the upper limb on Wednesday. So once again, that will be a fantastic lecture once again, like much of this series has been. So yeah, if you're free next Wednesday, please do attend. All of the links are available on our social media platforms and also our Facebook events as well. So yeah, and Dr. I, if you wouldn't mind just moving on to the next slide for feedback. So this is the feedback QR code. So if you wouldn't mind getting your phones out. I've also added the link onto this chat as well. I'm also going to send this onto Facebook now. Sorry, onto YouTube. I apologize. So everyone on YouTube should be able to get this feedback link as well. And yeah, please do fill this out. I can't stress how important it is for us to hear back from you to see how we can improve. And also, this is very nice for Dr. Iyer as well, for giving up her time so she can receive some feedback for this talk as well. So yeah, please do get your phones out if you can, and get the QR code locked and loaded, and please fill this out as well. The link is also in the chat box once again. And yeah, that's all from us, I think. Thank you very, very much, Dr. Iyer, once again for giving up your time and for teaching us in such a lovely manner. And hopefully we can have you back again, talking obs and gynae again sometime soon.
I'm more than happy. I love teaching O&G stuff. Other stuff, I'm like, that's how I feel. There's a lot for me to brush up on. But I like teaching obs and gynae. I think often I just feel like it wasn't taught very well for us in med school because it was a very short block. It was just so much to learn. I felt like that about peds as well. I think the specialities is just not enough time to cover it. So yeah, definitely been happy
I completely echo your thoughts, and thank you so much for simplifying this. Hopefully, everyone here can leave with something incredibly important that they can incorporate into their physical exam practice as well. I say this after every single lecture, but hopefully everyone leaves with something. So yeah, I think that's everything from myself and Dr. I as well. So thank you once again, everyone, for attending this lecture, and hopefully we see you at our future events as well. Thank you, Dr. I, once again for coming on. Thank you for your time. And yeah, hope everyone has a great evening. And yeah, we'll see you next time. Thank you.
Recording in progress. Is that call?